Okay, we're going to go ahead and get started. Hello, everyone. I'm Crispin Delgado. I'm a program officer here at Blue Shield California Foundation. Thank you for joining the foundation today, and a big thanks to our partners and to the many other organizations that helped us spread the word about this webinar. We are very lucky to work with you. Almost a year ago, I made the transition from working for a safety net provider system to philanthropy, where I focused on improving access to affordable, quality care for all Californians. I emphasize quality because it is not just about getting people through the door, it's about engaging them as patients. But how do we do this work, especially in a safety net setting with limited resources? Over the past 3 years, the foundation has set out to learn more about how low-income individuals gather and use information and how they prefer to communicate with their providers. The hope is that this work helps safety net providers better serve patients and better realize the promise of health reform. This research has been based upon statewide surveys of more than 1,000 residents, providing us a unique inside look at what real Californians think about their health care. The findings represent universal truths that patients want clear information about their health, close relationships with their providers, a voice in their decisions, and more. We intended for this body of work to inform and support the community health centers that make up the front lines of our safety net system. However, the implications are bigger, broader, and more applicable than in just the safety net setting. The information is useful for anyone working with low-income patients. If you're a private provider or public hospital who sees low-income patients or a specialist serving immigrant families, there is something on this webinar for you. There is no better time than today to be engaged in this work. As more and more low-income Californians enroll into health care coverage, the safety net will face new challenges and competition as they work to effectively provide for and retain their patients. And as you can see from our current grant portfolio, we are working to find solutions on how to make this transition more manageable. Many health centers are already working to test innovative models, implement new technologies, and form new partnerships that expand their capacity and ensure access to care. All of these things are important for health centers to succeed in a post-reform landscape. However, effectively leveling the playing field for low-income Californians at a systems level boils down to just 10 critical components. You don't have to do all of them, but you can't do none of them. Today, we'll walk through what these 10 important findings mean for your organization and for the future of California's healthcare safety net. Gary, if you could please switch over to the next slide for me.
Absolutely.
The foundation was lucky to have partnered on this work over the last 3 years with Gary Langer and Julie Fallon of the Langer Research Associates. Gary is an internationally recognized public opinion researcher with expertise in analysis, questionnaire design, and survey methodology and management. He has more than 25 years in the field, is director of polling at ABC News, and has overseen and analyzed more than 750 surveys on a broad range of topics. He's also joined by his senior research analyst, Julie, who has honed her research expertise by examining how people think and what influences their behavior. She combines strength in diverse research methods and sampling techniques with advanced statistical skills and is the winner of multiple research awards. Today, Gary will share the major takeaways of the research and dive deeper into the analyzed data to uncover what's most useful, most meaningful, and potentially most transformative for California's community health centers. Then we'll hear from Vinu at the Center for Care Innovations and Val Sheehan from the California Primary Care Association, who will share some reactions to the data and what it means, and still have plenty of time at the end for questions and discussion. A big thank you to Apana, our program assistant, and Aida Pelton, also on our public affairs team, for helping us put this webinar together. Again, just a reminder that you can chat your questions to all panelists as they arrive, but we'll wait until the end to address them. Thank you for your patience, and Gary, you can take it from here.
Thank you, Crispin. It's been great working with Crispin and his colleagues in putting this research together. I'm grateful for the foundation, and especially grateful for everyone who's joining the webinar to participate in this call. I hope we share some useful insights with you, and I look forward to the questions at the end. I'm going to walk you through some slides. First, to tell you about an overview of what we've been after here through this research. Essentially, the work was born of the vision of Peter Long there at the foundation that we're going to face a new world for safety net facilities, for community health centers in California, as we navigate the changes brought about by the Affordable Care Act. We need to identify cost-effective paths to primary care redesign in a way that's more appealing and sticky, if you will, with patients. And we'd like to determine the motivators of patient satisfaction, empowerment, and efficacy, and to identify strategies by which we can achieve them. We've tried to do this now, as Crispin mentioned with a series of 3 successive statewide random sample surveys over the last 3 years, 1,000 interviews apiece, 20 to 25-minute questionnaires, really going in depth into patient experiences, preferences, and attitudes. We've produced 6 major reports and a variety of briefing papers and presentations, just like this one. So what are we seeing here? I think the key conclusions we're finding is that a patient-centered approach is critical. Patients who feel a personal connection with their caregivers are more informed, engaged, and satisfied with their care. We really found what we think we can describe as 3 keys to engaging patients. Connectedness is the first, a sense that someone at your healthcare facility knows you pretty well. Continuity, seeing the same providers over time. And then patient-provider relationships, by which we mean the level of trust, communication, and collaboration that patients feel they have with their providers. Now, I'm going to be talking about each of these and how they inform the outcomes we care so much about in terms of patients who are empowered, who are engaged in their care, efficacious, who are satisfied with their care, and through that satisfaction, loyal to their care facility. Satisfied patients, we find, are loyal patients. As I present these results, I'm going to use the word predict or predictor from time to time. That refers to in-depth statistical analyses we've performed on these data using regression and mediation analyses. My colleague Julie Phelan's been terrific on this work, in which we, by holding all possible factors constant, demographic and attitudinal data alike, try to predict and see which are the strongest individual indicators of the outcomes we care about. And those results are ones that I'll refer to, and more detail is available, of course, in the reports. What we've come up with after these 3 years of research and these analyses I've described are really 10 things, I think, that health centers can do to position themselves for a successful future by engaging and involving their patients and therefore better satisfying. Health centers can do a variety of steps, some quite specific. Develop team-based care. I'm going to talk about each of these in detail as we go through. Providing navigation for patients. Connecting more broadly and communicating with patients effectively. Encouraging patient involvement in care. Delivering clear information in a way that patients can access and use it. Supporting patients in major medical decision-making. Offering patients email and text messaging options, developing new ways beyond those, also often including and involving technology to engage patients, creating an inclusive and welcoming environment, and getting team buy-in on the effort, because it takes a village to accomplish some of the goals we're going to be talking about today. All right, let's take these one at a time. Team-based care seems to be an almost uniquely powerful predictor of patient engagement and satisfaction. The blue lines on this screen are the results among patients who have team-based care. The orange lines are the results among patients who don't have team-based care. Patients with team-based care, as you can see, are 20 points more likely to feel they have a personal connection with the facility where they go for care. They're 14 points more likely to have continuity in their care. Back up to 19 points more likely to feel very informed about their health, to always understand their provider's explanations, and also more likely to feel comfortable asking questions, those sort of quality of relationship measures. They're all considerably higher. These are very substantial margins among patients who have team care. How many do? In our data, about a third, or one-third exactly, of low-income Californians tell us they have team-based care. That leaves a pretty wide playing field to expand this really quite successful pathway toward patient engagement. It's also encouraging to see that among patients who currently do not have team-based care, 72% are very or somewhat interested in it. So again, we see broad possibilities here in the extension of team-based care to more patients. Providing navigation for patients is another example, and this can be either within or apart from a team-based care format. Again, the blue lines are patients who have a navigator, navegadores de salud, who work with them. The orange are among patients who don't have a navigator, and again, those who have a navigator helping them through the system. are far more likely to feel connected with their facility, to have continuity in their care, and to feel informed, to have comprehension, and to have comfort asking questions of their providers. Those good engagement outcomes are strongly predicted here by having a navigator. Currently, about 2 in 10 low-income Californians have a healthcare navigator, meaning there's even broader here opportunity to expand this service. There's somewhat less interest, perhaps because it's less familiar, in having a navigator. Half of Californians in this population tell us they're very or somewhat interested. There's opportunity there, and I think a need for health centers to communicate the benefits of a navigator, as with team-based care, to patients, given the effectiveness of these approaches in creating greater connectedness, continuity, and communication. Okay, so if team-based care and working with a navigator are individual strategies, we need to open it up somewhat to take on the broader concept I've mentioned about connecting and communicating with patients, and to walk through that now from connectedness, continuity, to patient-provider relationships and the impacts we see from them. This is an essential area for health centers to focus on and to promote, regardless of whether that happens within the confines of team-based care and the use of navigators or other approaches that we'll talk about. Right now, just 38% of low-income Californians feel a personal sense of connection to their facility, so there's broad room to expand and improve upon that. More, but still not an overwhelming majority, 53% say they seem to see the same provider all or most of the time, that continuity measure that we also find is so important. So there's room for improvement there as well. The importance of connectedness and continuity appear in this model of patient engagement that we produced last year. Connectedness and continuity here, independently, holding other factors constant, predict these important measures of empowerment among patients, feeling informed about their health, comfortable asking questions, saying their provider explains things in a way they understand, and being confident they can make healthcare decisions. These, in turn, independently predict engaged patients, patients who are involved, who take an active role in their care, and engagement, as discussed, leads to satisfaction and to loyalty. These empowerment measures we've opened up somewhat in our more recent exploration of the data to the concept, as I'll bring it on next, of patient-provider relationships. Patient-provider relationships, as discussed, are really best understood as the extent to which patients feel they have a rapport with their care providers. They can talk with them, they can bring in information, they can ask questions, they can understand the answers, they feel engaged to participate, encouraged to participate in their care. Among patients who feel a personal connection with their care facility, 75% have stronger than average patient-provider relationships. It falls off dramatically among those who don't have a sense of personal connection. Continuity of care as well. Among those who have continuity of care, we're far more apt to see a strong patient-provider relationship. So the relationship there is clear. Now, great things are associated with having the strong patient-provider relationship I've described. Patients who have a strong, that is above average, patient-provider relationship are vastly more likely to feel very informed about their health, as you can see here, and to have the information they feel they need to make informed decisions, things we really do want patients to do. Patients with a strong patient-provider relationship, likewise, are much more likely to rely on doctors for their information, to trust information from doctors as well as from other medical staff. And individuals with a strong relationship with their providers are vastly more likely to express satisfaction with their care overall. A 35-point margin here is really quite dramatic. To say their provider encourages them to take an active role, to have the amount of say they want, and to be very confident in their decision-making ability. Really what we're seeing here is that connectedness, continuity, and the strong patient-provider relationships that they inform have tremendous outcomes. We get there by explaining things clearly, inviting questions, helping patients feel comfortable, bringing in questions and outside information, and encouraging them to express their own preferences. One simple but effective step is simply to encourage patient involvement in their care, really a key concept, a goal of patient-centered care. Currently, 7 in 10 patients say they are encouraged to take an active role, and that's encouraging. That's a good result. It does mean there's a substantial number who don't feel that encouragement, who really should, and I would suggest there's probably ways in which we can deepen as well as broadening the sense of encouragement. It is quite important. The patients who say their provider encourages them to take an active role are far more likely than others to feel highly informed about their health and their health needs, and to say they have the information they need to make good decisions about their health. In terms of quality of care, patients who feel encouraged to take an active role are nearly 20 points more likely to be satisfied with their care overall and to have the strong patient-provider relationships we've discussed. What else can we do? Delivering clear information is another essential element on this path to patient engagement. Effective information and communication when provided to patients helps produce enhanced patient-provider relationships, which lead us to empowered and engaged patients who are then more likely to seek more information and to communicate better about it, continuing, if you will, a virtuous cycle of patient engagement as we go forward. They're showing again a piece of the chart I showed earlier. You can see that information has a fairly uniquely powerful role in this process of patient engagement. Feeling informed about your health individually predicts the other empowerment measures: comfort asking questions, understanding answers, being confident, as well as predicting, along with the others, that goal of patient engagement. It's important to note, though, that information can be off-putting, overpowering, intimidating, as well as useful. When we first ask patients, do you have all the information about your health that you need to make good decisions, or would you like more information? A kind of tepid 55% say they'd like more information. When we then say, well, what if the information were clear and easily accessible? Well, then interest in having additional information to make good decisions increases quite dramatically from 55 to 71%. Telling us that it's not just about delivering information, but delivering information that's targeted, it's comprehensible, that's accessible, that's usable by patients. That makes all the difference. It matters because patients who feel very informed about their situation in terms of their health are vastly more likely to be comfortable asking questions, to understanding answers, to being confident, and to feeling they have a great deal of say. In terms of decision-making, again, we see the really important element of clarity in the provision of information. And when we ask patients, this is sort of a principle of patient-centered care, the assumption that patients want an equal say in their care decisions. Outright, when we ask patients in this population if that's so, the majority do, but it's not an overwhelming majority. 59% say they want an equal say. But then we say, well, what if clear information is provided about treatment options? In that case, how would you feel about it? And the preference for equal say in care rather than leaving decisions about care to care providers jumps from 59% to 81%. Indeed, what we find here, an important result, is that this sort of clear information and accessible, usable information attenuates group differences and you might say levels the playing field among population groups in the provision of care. Initially, if you ask people if they want an equal say in their care, the answer is yes among far fewer of those who have not gotten through high school than it is among those who are college graduates, a tremendous 25-point gap. When we say, well, what if clear information is provided about your options? As you can see, the gap based on education is significantly attenuated, in fact, no longer as significant. We also see significant reductions in the gap between Anglos and Latinos and between non-English and English-speaking patients when we talk about not just information, but clear, accessible, and usable information. Important elements that keep in mind there. It's important also to support patients in their major medical decision-making. This is a subject of a new report just being released today in conjunction with this webinar. There'll be more detail there. But what we've done is identified 9 elements in the literature, 9 recommended steps that providers should engage in with their patients facing major medical decisions, listening to their preferences and concerns, asking about their goals, discussing multiple options, referring them to more information, and then talking about the various options that might be presented. What you can see here is that while individually some of these are being, or all of these are being provided to some extent, the use of these decision support activities is far from universal. In fact, a third of patients who faced a major medical decision in the past year say that they received only 2 or fewer of those 9 decision support activities. The plurality received 3 to 8 of them, and just barely more than a quarter received all 9 decision supports. This again matters quite a bit, the effort to engage patients in their decisions. It works across a continuum, but just for convenience to break it down here, we looked at the patients who received fewer than 5 decision supports, and those who received 5 or more. Those who received the higher number of decision support activities from their providers when facing a major decision were far more likely to say that they were very involved in the process and far more satisfied with the process as well. Okay. It's also important to take account of new technologies and to offer patients email and text messaging options. There is a digital divide, particularly in Internet access. 58% of low-income Californians have access to the Internet. That's compared to 87% of their higher-income counterparts in the state. So there's a dramatic difference there. There's a difference, but less of one in having a texting cell phone. Regardless, even among those who have Internet or texting cell phones, quite few in our low-income population currently are able to text with their provider or to share emails with their providers or facility. Those who do so find it useful, and indeed many find it very useful. Usefulness overall, 87%. So there's a positive there among those who have the ability to do so. Among those who have the technology but currently can't text or email with their providers or care facilities, a sizable majority, 70% or more, are very interested in doing so. And using these technologies, email and text, is another independent predictor of strong patient-provider relationships. Texting and email are almost old school by now. There are new ways to develop to engage patients and involve them in their care in a way that brings forward greater patient satisfaction and loyalty. Patient portal is one. Just 29% say their place of care currently has a portal, an Internet facility where they can go online, check their records, check appointments, manage their health information. 3/4 are interested in having a portal among those who don't currently, and among those who have a portal, 7 in 10 find it very or somewhat useful. It is another way to engage patients and another predictor of strong patient-provider relationships. We also have use of the Internet or software applications for a variety of health purposes, automatic messages, sharing experiences, finding information. We find that currently uptake of these is really quite low. Only 6 to 17% of low-income patients are using the Internet or software applications for any of these purposes. There is, however, a much broader interest in doing so than there is uptake at this time. That suggests that community health centers can play a role in assisting patients with the sometimes overwhelming process of finding information that is valuable, useful, and targeted on the Internet. And by serving a curatorial role, can increase their usefulness and indeed increase, again, patient-provider relationships and their link with patients while directing them to additional sources of information. Decision aids, whether they're online or through other sources, are another way to engage patients. Use of decision aids, again, does predict positive patient-provider relationships. It's not a lot of uptake now. 1/4 have used one. There's broad interest. 78% very or somewhat interested in using decision aids when it's appropriate. and those who use them, again, exhibit the greater patient-provider relationships. There's also some sort of low-hanging fruit, if you will. Creating an inclusive and welcoming environment is additionally an essential element of serving patients. Factors such as the courtesy of frontline staff and the cleanliness and appearance of waiting rooms strongly influence patient satisfaction. Cultural competency is another area that can have a big impact in patient comfort and satisfaction, and that's one, of course, in which CHCs, the community health centers, may have a built-in advantage given their long experience in that area. Lastly, again, I think team buy-in on the effort is essential. We're really talking here about a mindset that needs to run throughout the organization. Health center leaders and staff can come together, I think, around the goals of connectedness, continuity, positive relationships with patients. It's necessary to assess current practices really from the front room all the way back, and discuss ways to make patients feel more welcome and informed, engaged, and empowered to take an active role in their care. The results are really quite easily seen. I presented a lot of data on this, but I'll just give you one more. Among low-income patients who say that someone at their health care facility knows them pretty well, 64% rate the quality of their care as excellent or very good. Among those who don't express that personal connection, quality of care ratings are at that level only among 40%, 24 percentage points lower. Again, a dramatic difference we see in the absence of the personal connection that patients seek. Okay, I just want to mention a couple of other points. This webinar is being accompanied by 3 bits of research being released today. One is our third report from this current survey. I referenced it earlier. That's one about engaging patients in major medical decisions. You heard a little about it here, and there's more detail available. Another is an issue brief on 10 things health centers can do, which we're discussing at this moment. And the third is about strengthening engagement with low-income Latino patients. We find in these data that Latinos have lower satisfaction with their health care, weaker patient-provider relationships, and less trust in medical professionals. But these are not functions of their being Latinos. They're mainly functions of language and education levels, and as such they can be addressed effectively by involving and engaging in making Latino patients feel welcome while taking account for the socioeconomic factors, including their education levels and their language preferences. This can work for Latino patients. It can work for all patients. Really what we're saying here and seeing in these data is that making patients feel known and welcome, building continuity, encouraging their involvement, taking new steps to engage and clearly inform them, all these build the strong relationships that patients want and need from their providers and from which patients and their care facilities alike can clearly benefit. Just to conclude, we have some research resources. I'm not going to read them all in any detail, but I want you to know they're available here. You can find these slides on the Foundation's website. This is a summary of the reports we've put out this year and in previous years. The subject of each is described in a brief paragraph. There's much more data than I presented in this short discussion available that support and I think add additional information to the things health centers can do to involve their patients and develop greater patient engagement, satisfaction, and loyalty. So with that, I thank you for listening. I think we're going to turn it over back to Crispin and our discussants, and then Julie and I will be happy to take your questions. Thanks.
Great. Thank you, Gary. Now that we've heard from Gary, we're joined by 2 of our colleagues who will provide brief responses to the ideas just presented. In listening to their unique perspectives and experiences in the field, we hope to provoke further discussion and richer conversation as we moved into the Q&A. Our first response will come from Vinu Alak. Vinu is Executive Director of the Center for Care Innovations and will focus her remarks on how the findings on improving patient engagement are impacting grant making. Vinu?
Great, thanks Crispin, and thanks Gary, that was very informative. So as Crispin mentioned, I'm the Executive Director for the Center for Care Innovations, many of you know as a CCI, and our role is really in helping support the transformation of safety net organizations, doing that through developing programs, addressing key interest areas like patient engagement, providing technical assistance, bringing in experts and convenings, and providing grants. And over the past few years, we've partnered very closely with the Blue Shield of California Foundation to design a series of patient engagement programs, grant-making programs, and technical assistance programs to really support clinics in actively engaging patients in their care and improving patient experience. And the themes that were covered by Gary today in the study are very much in line with what we've heard from clinics as essential focus areas for developing patient-centered care systems and align with the program offerings in terms of specific things health centers can do. So I'm going to just touch on a couple of the programs and how they really tie to these themes, because I think they're very tangible approaches to addressing some of the themes that Gary raised. One really successful program we've offered a few times now is our Treating Patients with Care Train the Trainer program. And in this program, we partnered with the Institute for Healthcare Communication, who trained folks in health centers across the state to be able to train their own staff and providers to be able to communicate more effectively with patients and with one another. And this program's really focused on helping patients in terms of their connectedness to their team, also in strengthening the communication amongst the team, which, as we heard today, the team-based care and effective communication on the team is essential. And then also ties to the theme of really focusing on delivering clear communication in a very respectful manner. And over the last year have trained almost 4,000 people across the state, and is a program that's been very well respected by the clinics. Another program that also ties to the themes that were covered today is a program really to encourage patient involvement in care. And in this program, we partnered with the Institute for Patient and Family-Centered Care, and they've been working really closely with health centers to find ways to strengthen patient involvement by first starting by building patient and family advisors, and using these advisors to help really inform and get the voice of the patients into helping redesigning care, finding ways to address things like how do you build a welcoming environment that resonates with patients, how do you identify ways to improve communications. And many of the health centers have been developing both English-speaking and Spanish-speaking patient-family advisors groups, and are seeing the real value of getting patient and family voice into the work they do. Another program we launched last year is also ties to an important theme around text messaging. And we launched a program last year, just when this last report came out, around how to encourage health centers to create text messaging programs that will help both engage patients and address critical issues for the health center. So people are looking at things from improving no-show rates to better diabetes care management to, really understanding how to engage patients in getting better information about specialty referrals. So we're very excited about that program because we think this area of texting, email, and patient portals are very, very promising for underserved patients, both in terms of engaging them in their care, but also in improving access to needed services and information. And CCI is working with Blue Shield of California Foundation to launch a new program on really improving effectiveness of care teams, because as we know, there's huge correlations between the effectiveness of care teams and predicting strong patient-provider relationships, patient satisfaction, and just a little plug for that one. Applications for that program are due tomorrow. And then lastly, as we're queuing up our new programs in partnership with Blue Shield of California Foundation, we're really continuing to build on the important themes of the study around building connectedness, building continuity, and improving the provider-patient relationship. And CCI will be launching a new program this summer, and we're just in the process of defining what those offerings are going to be, but we will be continuing with our themes of finding tangible approaches that connect to these 10 things that health centers can do. And as we continue to support innovation and advancing new ideas, we're going to keep looking back to this study to make sure our work to help support health centers create patient-centered care systems resonate with these themes well. So thanks, Crispin, for allowing me to say a couple words.
Great, thank you. So now we're going to hear from Val Sheehan. Val is Director of Development and External Relations for the California Primary Care Association, and will share what these findings mean for clinics and other safety net providers invested in strengthening patient care. Val?
Yeah, hi, Crispin. Thank you so much, and thank you, Gary, for the great presentation. For those of you who don't know, CPCA, or California Primary Care Association, is the statewide association for community clinics and health centers. We represent nearly 1,000 sites serving over 5 million patients here in California. So the data that Blue Shield has been putting out over the last few years has been completely instrumental into what CPCA has set out in terms of our strategic direction. I think a great example of this is the first research that came out in 2011 talking about the preferences of low-income Californians. There was a key finding in that report about low-income patients desiring to look at alternatives to who they're currently seeing in terms of providers. And this was really important in informing a bold step that we developed in our previous strategic plan on branding. And that helped us sort of really move to action around articulating who community clinics and health centers are and what value they bring to patients. I think also in our previous strategic plan, we had a bold step around patient-centered health home and helping our members achieve patient-centered medical home recognition, but also looking past that, we believe in trying to help the health centers actually transform the care that they deliver. So that report definitely influenced that report and subsequent reports influenced our strategic planning. In terms of training and education, again, we've partnered several times with the foundation to bring this information to our members. This has been done over webinars to our members. We've had Gary and the foundation staff also present during sessions at our conferences. And in fact, one example of how we're trying to bring a lot of this information to bear with our members is through a specific conference we have around patient-centered medical home and health information technology. And that conference is coming up, but we have sessions that are addressing, sessions that are being led by health center staff talking about their use of patient portals, texting, what's working for them. I think another value add that we have at these educational sessions is that we often have vendors or other providers of these services there at the conferences so that our members can connect with them and learn more about how they can bring those services into their health centers. And then I'll just conclude, because I'm very anxious to hear what some of the questions are. I'll conclude by saying that we are in the midst of developing our next strategic plan that will inform the next few years. And again, we are really looking to the research that's coming out of the foundation to inform what we do. We know that there will be a portion of our strategic plan that will really focus on health center transformation, how we move our health centers from being where they are today to being the providers of choice for tomorrow. So a lot of this data, I've already forwarded the issue brief because I was lucky to get an advance copy. I've already forwarded the issue brief to our staff, and we're already looking at these 10 steps, how we can integrate them into our strategic planning process, and then how can we bring that to our members, and how we can continue to bring a lot of this innovation and harness what we're all doing, again, to truly transform how care is delivered inside our health centers.
Thank you, Val and Vino, for being willing to share those insights and for leading us into our question and answer session. Now it's time to hear from you. We've already collected a number of questions. However, I would encourage you to feel free to submit additional comments by chatting to all panelists at any time during this Q&A. We will try to get to as many as possible. And just as a reminder, a recording of today's webinar will be posted on our website along with all the current and past reports. And with that, I'll move over to the first question. And that is, Gary, could you tell us a bit more about the low-income California survey respondents what they look like, including their demographic profile and where they seek care?
Yeah, before I do, just a quick comment. I'm going to bring in my colleague Julie Phelan to help me with some of these questions because I think you've heard enough of me, and she's got great insight as well. I also wanted to mention that before launching any of these surveys that we've produced to date, we've taken advantage of the goodwill of a group of really strong and deep professionals in the field who we've interviewed and talked with at depth about the areas to cover and bounced our questionnaires off them and really gotten some great insight. And both Vino and Val are among that group, and they've been terrific and invaluable in our crafting the research to date. And I just wanted to make that comment and give them my thanks. The population profile of low-income Californians, which is, I think we've defined, I should say, as those at less than 200% of the federal poverty level, is as you might expect. And I'm going to speak somewhat from memory. Julie can jump in and perhaps pull some data while we're talking, and it's also available in our reports. But it is a population, obviously, that compared to the higher income population has lower education. A lot that
I have the numbers. Do you want me to jump in?
Yeah, if you have some data in front of you, why don't you go ahead?
Yeah, about a third have less than a high school education. 53% are Latino. I think you also asked about where they go for care, and we have almost half are going to some sort of clinic, including 16, 17% who go to community clinic or health centers, 25% go to private doctor's offices, and about 10% go to Kaiser. What other demographics?
Well, there are differences, as you could expect, by language, immigration status as well. The ones, citizenship, the ones you might expect. One thing that's an interesting point I think I'd like to make is that patients in the low-income population who are get their care from clinics look in many ways qualitatively different in terms of their experience from those who go to private doctor's offices for their care. However, clinic patients who are enrolled in team-based care programs look very much like private doctor's office patients in terms of their information and their satisfaction with their care. It is the clinic patients who are not engaged in team-based care and therefore not pulled in to a connected and a strong patient-provider relationship among whom we see a sharp drop-off in satisfaction. And that's, again, why it's important to recognize that what gaps exist by education or language or other metrics can be bridged by bringing patients forward into a strong relationship with their providers, and that's really the underlying message here. It's not about the differences so much as how to bridge them.
So great. I have the next question. And there was actually two questions that were fairly similar around navigators. And so the question is, does the training level of the navigator matter? And then also, how do you define navigators? Are they clinical or non-clinical, volunteer to paid? So if you could just dive in a little bit deeper about what you meant by navigator, that would be great.
Well, I could read you the question we asked, and that perhaps that's a good way to start. We say this. We say this. Some places have a person whose job it is to help people get the appointments, information, and service they need, make sure their questions have been addressed, and it may even call to check in on them between visits. There are different names for this kind of role, for example, a healthcare navigator or a healthcare coach. And then we go on to ask, do you personally have a healthcare navigator or coach at the place you go for care? So that's how we define it. One might expect that a navigator who's better trained, who's got greater experience would probably be a more effective one. We don't have that measurement in our data. What we do have in our data, as described in the slides I showed you, is that simply having a navigator is a good indicator of patients who are more engaged, have more information, have better connections with their place of care, and who have greater satisfaction as well.
Yeah, I would just add that even though we don't have data on it, anecdotally, we did speak with a lot of experts in the field before we did our research, and at least one, and I think several, talked about how it doesn't need to be somebody with clinical training. It's just that point of contact and that sort of continuous relationship that matters. So, you know, that's anecdotal evidence, but it does suggest that they need not have clinical training.
Great, thank you. So this is regarding the term engaged that you've used, and so one provider wanted to know, how do you determine if a patient was engaged with their doctor or facility?
There's a variety of measures. Julie, you want to pick it up?
Yeah, the core engagement measure is how much of a say in care decisions do you have. That's not exactly how it's worded, but that's the basic definition of engagement, is how much of a say in your care decisions do you feel you have. And then we also have various other questions that get at engagement, including you know, asking people who faced a major medical decision in the past year how involved they felt they were, whether they would have liked to have been more involved, that sort of thing. So all of those things tap into the engagement.
Great, thank you. So it looks like this next question is actually for me, which is, does the foundation anticipate future funding opportunities for organizations working on the 10 things? As Vinu mentioned, we've partnered with the Center for Care Innovation over the past several years, and a lot of that work that we've done in conjunction with CCI has focused on key findings from the Langer research. Like Vinu mentioned, tomorrow is the closing deadline for a funding opportunity around team-based care. And so a lot of the work that we're currently engaged in has been shaped by the key findings from previous and current Langer reports. And so we do continue making investments. There is no additional called out opportunities at this point beyond the team-based care RFP. But thank you for your question. So now we're going to go back to another question for you, Gary. During these surveys, were the types of providers, such as dentists, parsed out, and they wanted to know were there questions specifically about the types of providers offering services?
We didn't parse out dental care per se. We did ask patients where they got their health care and broke that fairly finely into a variety of categories, into clinics or non-clinic care, and then within the clinic structures, hospital clinics, community clinics, and the rest. So these categories are broken out in the report, and there are a variety of care experiences across the different provider types. Again, I think the important thing is not only to focus on the differences that we see, but really to try to learn what informs those differences as ways of addressing them and bridging the gap between the sort of the haves and have-nots in care, even within this population. But if the question specifically about dental care, we don't break out care type to that extent in this research.
Yeah, but our question does say when you're sick or need health care. And also, I would just add that when somebody said they went to a clinic, we did cross-check it against lists of both public and community clinics.
Great, thank you. So this is another one about the types of healthcare personnel. So it says, what types of healthcare personnel do you think could or would increase the connectedness and continuity of care?
Well, when we talk in our question about team-based care, we describe that, as patients I think experience it, as a healthcare team that can include a doctor, perhaps a navigator, a nurse, a physician's assistant, a health educator. There are various elements or components of a team. I think the attraction many see in team-based care is that it needn't be the traditional doctor-patient relationship. It is rather a far more scalable use of the facilities and resources available. The patient doesn't always need to see the doctor and may need to see different doctors, and a team makes that available to them in a way that is more cost-effective, if you will, more sustainable than the traditional doctor-patient relationship. And the important piece here is that while patients may say or think that they want is a regular personal doctor, what our research finds is that what they mean they want is connectedness, continuity, and a strong relationship. And when they have those, they predict satisfaction with care, and having a regular personal doctor does not.
Great. So this was a follow-up question to the demographic overview that you gave, but they were wanting to know what the income amount that was used to determine the definition of low-income Californians, and they also wanted to get a better sense of the age range of the people that participate in the survey.
Sure. So the federal poverty level is determined not just by income, but also by size of family, the size of the household, actually. So I believe, gosh, for this year, Gary, do you remember size of family of four? What was the income?
Around 40,000. Does that sound right?
I think it's around 40,000. Yeah. But so then the income breaks among our less than 200% federal poverty level sample. 29% make less than 16,000. 46% make between 16,000 and 31,000. And you know, very few make more than that. So 16% make between 31 and 52. But again, it's not just income level. It also depends on how many people are in the household. And in terms of age, we have a third are under 30, 23% are 30 to 39, 21% are 40 to 49, and 23% are 50 to 64.
Great. Thank you.
I should mention that we did exclude seniors from the sample, given their alternative or other arrangements, if you will, for care.
Right. Oh, great. And so if we still have Vinu and Val on the line too, I think that they could chime into this next question as well. But it says the 10 actions are very exciting. How are the clinics financing and sustaining the adoption of these steps in the current PPS model? So I know, Gary, that as we sort of explore these different 10 things, we weren't taking into account very much the cost of implementing them, but I didn't know if you wanted to speak to that.
Well, you know, this is one that I think actually folks like Vinu and Val might be better equipped to comment on. It is a challenge in that the payment structures have really not caught up with the realities of patient needs and the directions in which CHCs and others need to go. We labor within a pretty old-fashioned payment structure that doesn't easily, perhaps in all cases, accommodate those. But I think there are and have been efforts to move ahead with that. And indeed, we think that some of the solutions we suggest here are scalable in a way that should be quite cost effective. But beyond that, perhaps Vinu and Val have comment. I don't know.
Yeah, this is Vinu. I mean, the thing I would point to is many of these things are not super expensive. It's more of a change in practice. So. And can align with other things that are going on, like existing pay-for-performance programs or patient-centered medical home type efforts, and some of the meaningful use requirements, which are encouraging, actually, a lot of these activities to happen. So a lot of the team-based care, some of the texting and portals and email with the meaningful use moving forward. Some of the things around building patient-family advisors definitely have some startup costs to get started and have a coordinator, but then over time, you know, once it's going, not as expensive, but I think people are just finding in the clinics that are sustaining this work are really just finding that it just becomes, you know, incredibly valuable to being able to do work more effectively, and sometimes it can be cost savings because you end up cutting out things that patients don't really want and need and focus on the things that really do meet their needs. So things like navigators and when you're adding staff, I think are more challenging, and go back to Gary's point about like trying to get some of the payments, you know, as payment systems are changing and evolve may help. But I think there are a number of these things that can be done which are not incredibly expensive and are really just critical to helping support the patient-centered culture.
Great. So we have a couple more questions for you, Gary, in our last few minutes. Was there any work done on how the use of online resources like WebMD correlated with their level of engagement with their providers?
Well, I'm going to ask Julie to help me with this, but the short story is that one is we do not find a lot of uptake of online resources. They're available, there's interest in them, but there's not a lot of use of them at this point. And we think that may be worth more exploration, but we think that it may be because it's somewhat intimidating. There's a lot of information. It's not highly trusted. Online sources are not nearly as highly trusted as medical professionals. And I think there's therefore a clear need and a good opportunity for health centers to act in a curatorial role in which they use these online resources, but recommend to patients which are and are not valuable and worth their time and useful, and use the online resources to encourage patients to become yet better informed and involved, but to do so in a way that bounces back to the clinic's own usefulness and or the health center's own usefulness and reputation. Julie, anything to add to that?
I mean, we didn't look at specific websites is one thing. We asked more generally about, using either apps or the internet for various health reasons. And we were really more interested in looking at whether using the internet had a positive impact on patient-provider relationships, connectedness, that sort of thing. And we did find that using this technology did predict more positive or stronger patient-provider relationships. I don't know that we looked at whether it predict feeling more informed, because that wasn't really a focus of this particular report. But it's something we could certainly look into. But we definitely didn't parse it into specific websites.
Yeah. Overall, though, I just point out again that I think the number was 17% of low-income patients who are online use the internet to search for health information. So the uptake is really far below what it might be. And doing so, some health professionals may think it's an intermediary that will interfere with patient-provider relationships. Rather, to the contrary, it seems to enhance them.
Great. So here's the last question, Gary. So I know I'm one that's really excited about this new Latino issue brief that was published today. Were there, as you look at and reflect on this new issue brief that was created for the first time ever, were there any overall findings that were very different for this population, or was there anything that surprised you in this analysis?
Well, I think the best news for this analysis is that we needn't simply take the gap in performance that exists, in experience, I should say, and accept it as an inescapable reality. We did an earlier brief in which we looked at the experience of care between low and higher income patients, and we found that there's a gap in satisfaction and in engagement and in involvement. And the same with Latinos. There's a gap. Latinos are less satisfied with the care, less involved, and less trusting of medical professionals. But that's not about being Latino, and I think this is the important takeaway. It's about education levels, it's about language of preference, and it simply tells us that engaging Latinos takes additional effort and takes a sensitivity, cultural, linguistic, education, and otherwise, but that health centers, which are particularly well positioned to make that extra effort, can benefit their patients remarkably well and cement their own position as well by doing so, by taking that extra effort to involve and engage patients at the level and in the manner that is most effective.
Great. Thank you so much, Gary. This has been very insightful. So we encourage all of you to explore the 3 reports and 2 issue briefs in greater detail. As I mentioned at the beginning of the call, I'm going to be following up with an email on how to access that page. This is only the beginning of an important conversation where we better understand what many of our patients want and need. We look forward to working with all of you to achieve the goal of improved patient engagement and better care. All of the slides from today's presentation, an issue brief outlining the 10 elements for community health centers, as well as a host of other resources related to this work, will be available on the Blue Shield of California website. Once again, thanks to our wonderful team here at the Foundation, Ampana and Aida, and our wonderful consultant, Ingrid Happel